I'm just stop your share. Okay.
You can start.
1 minute, sir.
Okay.
Yes, now you can start, sir.
Okay. Good morning, everyone. Today we are starting with the fourth session of our ISP.
Excuse me, sir.
Yeah.
First, permit other people in the waiting room. There are people in the waiting room.
Okay, 1 minute, sir.
Yeah.
There are 114 people.
Yeah. Admit them.
Admit all.
Yeah, admit all. Sir, now you can start. Anirban, sir.
Okay. Is it live?
Yeah.
Yes, sir. Admit all, sir. Give an admit all option.
Okay. Fine. So, good morning, everyone. I am Dr. Anirban Chatterjee, periodontist and implantologist from Bangalore, India. And I'll be very happy today for the fourth session of our interaction with the Australian Periodontal Society with ISP, which our president, Dr. Nifia Pandit Madam, has forwarded and we have started. And along with me, I have Dr. Neeraj Deshpande, our treasurer of ISP. So let me introduce today's speaker, Dr. Wang Lai, who has been, I think I have spelled it right, or in short, right. Yeah, and who has been nicknamed as Lizzie, which we call her in a common name of Lizzie. She has done her BDS completed BDS in the year 2010 from University in Otago in New Zealand. Then she went on to come to University of Sydney, Australia, where she is Master of Pain Management in 2013. Then to Royal Australian College of Dental Surgeon, Australia, where primary exams were achieved, and went on to do her specialty in periodontics in 2017 to 19 in Griffith University, Australia. And she has been a member of RACDCA specialty, that's periodontics, from Royal Australian College of Dental Surgeon. She has been a brochure speaker about pain management, which she has a specialty on. Her interest had been in photography, cooking, swimming. She is an avid swimmer, and she has been working experience with dental clinics at Griffith University, oral health centers, so on and on. She has a very big, huge level of education, which is going to share with us. And she's going to speak about a very, very important topic about dental anxiety and pain, which all the patients in our, in all part of the country will be feared. A fear psychosis about going to a dentist is always there. So she is going to help us speak about how to overcome this fear psychosis among the patient and what needs to be done about dental anxiety and pain. So here I bring upon Dr. Wang Lai or Lizzie to you. Over to you, Dr. Lizzie.
Thank you, Dr. Chatterjee, for the lovely introduction. So yes, today's topic is management of dental anxiety and pain. And I'm very honored to join you guys here. The reason I will be covering this topic, apart from me being a periodontist, so I'll just blend in a little bit with the group, is that I've done my master in pain management with the University of Sydney before specialized to become a periodontist. So very often people tend to think going to the dentist will leave them with only option of topical gel and local anesthetics. So today's whole point is to ensure we all understand there's much more than that, and those two are not the only options for our patients that very often experience anxiety. So let's get started. with our learning objectives. I would like by the end of this presentation, we all get to understand the key factors of anxiety in our patients. So it's very important how you screen patients and identify the key factors, because obviously if we're not able to identify the correct etiology, your management may not be correct. The other thing is understanding the concept of pain. We won't go too far into the physiological, neurological, like how it's transmitted through the nerve to the brain. It's more a general concept of what is pain. Then we're going to move on to basic life support. Now, whatever option it is coming along in anxiety management, I think this is a very important thing. As simple as it is that we have all been well trained, it is important to have the revision, because whenever we consider anxiety pain management, we're talking about some form of medication use or pharmacological use. And this is where you have to be prepared for basic life support when the unfortunate scenarios happen. I would like all of us to be familiar with the different terminology, because I have seen too many misuse of terminology in this field. What is anesthesia? What is analgesic? What is sedation? So these have all been quite confused, and I would like to set this terminology straight today for everyone. Then we're gonna go into more practical. I would like that this is not a theoretical lecture. I would like that tomorrow you actually can implement some ideas in your practice. So we're gonna talk about practically different options on top of topical gel and local anesthetics. So namely, we have oral sedation, inhalation sedation, conscious sedation, and GA. Now, obviously, I'm not teaching all of us to do GA. That is only to be performed by anesthesiologists. But us, as the periodontists or dentists or hygienists in the group, our job is being able to identify the patient that will benefit from GA and make such arrangement with the anesthesiologist. We will talk about under the different sedation option, what would the patient behave? Whether it's behavioral or physiological, how would they act? What will we be anticipating when they are under such treatment? So that when we are still focusing on our dental or periodontal treatment, we need to be able to observe signs and know when to react and monitor. I will be discussing a few case scenarios just to wrap it up, so you have a more understanding in how to decide in what cases what options should be offered, and we'll finalize it with some summary. Okay. So let's start with the dental anxiety and pain background. Now, this is what we all imagine we look like when the patient look up. Beautiful, handsome dentist, beautiful periodontist here. But in real life, a lot of them view us like this. Okay, so when they're anxious, everything is amplified. Okay, they can see things much more negative, although it is neutral. And what we would really like to achieve, okay, in this lecture, in our topic, is to achieve the results where patient will view it more like this. Okay, so they have more blur vision or memory, and when they walk out, it feels much more pleasant, because clearly the fact that they are identified as anxiety patient, some reasons are behind in the background. So what is dental anxieties? It can be triggered by different factors. It can be objective and subjective. So objective, very typical, needle. People tend to get really scared of needle. Now, I don't know if there's a lot of people that tends to get tattoo in India. In Australia, it's very common. A lot of people have it. And it's not uncommon that I get guys come in, really big guy and full body tattoo, and they go like, oh my God, is that LA gonna hurt? So just be mindful, it is the perception of anxiety, because the needle they use, they usually call it size 12, okay, for tattoo, which is actually thicker than our 27 or 31 gauge, where you use it for your IDB or whether you use it for infiltration. What they have is actually significantly thicker. And when we are injecting, remember how far we're going, especially for infiltration, 1 millimeter. It's not any more than they do, okay? So some people are more scared of drill, the vibration, the noise, and the smell. Please don't forget the smell, because in all the sensation we have listening, so your audio, your vision, your smell, your taste. Smell is the strongest sensation olfactory that is least forgettable. Okay, so people would tend to remember and recall memory most by linking up the smell. And what is the most common smell we can experience? Probably some bleach in the hospital smell, or inside the mouth, because it's a really intimate thing. Unlike the doctor, more or less, have a chat, discharge. We are really getting into people's smell. So what they can smell is the latex gloves or nitrile gloves, the rubbery smell. It can tend to trigger a figure as well. Subjective factors. Subjective, obviously, it's really up to individual. It can be past history, so they would have shared some bad story with you. When I was young, the dentist was putting his knee on my chest and ripping it out, or learned by observation. So it's more common in pediatric or children. They saw other people going through it and they felt it's gonna be scary for them as well. Be mindful of individual pattern of attachment. So you definitely have those that you're actually gonna do a huge, 8 implants in the upper jaw, need a huge GBR, and sometimes they can be quite comfortable and say, just go ahead, just LA, I'll be comfortable enough. And obviously we very often have patients during consultation getting a little bit hesitant to commit to treatment, even just for non-surgical debridement due to anxiety. And a lot of them can also benefit from the most appropriate level of anxiety and pain control. So it's really just up to us in identifying anxious patient. When we talk about identifying, it's important that we know that it's not about just asking. You have to ask in the appropriate manner. So when you ask the patient directly, if the wife is in the room, or the mom and the dad is in the room, or whoever, like the girlfriend's in the room, maybe it's unlikely that they will admit to you they're actually quite scared. So you're not able to screen it through. It's very, very often that dental anxiety is underdiagnosed. So this is not something by study, but I would just like to share with you what we do in our periodontics practice here in Australia. With the new patient, when they come in with the medical history form, we have that question. We do ask them. So it's very simple. You just use a scale of 1 to 10. So 10 is extremely terrified and 1 is completely comfortable. We usually ask them what level they are when they fill up the medical history form. We already include this question. And then next up, we will ask them, is there particular factors that will trigger them and concern them? So we don't want to use the word anxious in the question. We'll just say, is any factors that's going to concern you? Sometimes they are concerned actually about the cost, finance, and the time management. I'm a very busy person. I know I have a problem now that I'm seeing you as a specialist. How often do I have to come in? And then other times it's about anxiety. So that they can start, writing some notes down, or we actually have the boxes for them to tick, whether it's needle, drill, noise, combination, and all of those. So this is important to help you identify it. And make sure it is not undermined. So now that we have actually started implementing this question in all our new patient medical history form, you will realize very, very rarely you get it reported to be 1 out of 10. Okay, so to some level you get some 2 or 3, you're already very lucky, and most of the time they report to be 5 or above, because when people come to specialists in Australia, it's by referrals. I don't know if it's the same in India, but people don't directly come to us say, oh, I've got a problem, I need to see a periodontist. They would have seen a dentist, and because there's a severe problem, they are referred to the periodontist. So people know when they have to see a specialist, there is some level of severity and there is some level of complexity of treatment involved. So now, concept of pain. It is the most common symptoms any doctors are called to treat. Okay, it's estimated at any time point, like right now, this second, 20% of the adults in this whole world is suffering from some kind of pain, any kind of pain. Okay, in combination, like this is a way higher number. 20% is way higher number than the three most deadly conditions combined together. So we have cancer, 0.5%. We have diabetes, 6%, which affect probably you and me a lot because we are Mongoloid. We have the special gene, and then 6% for the heart disease as well. So be mindful, 20% of the time, someone is 20% at any second, someone is suffering from pain. And this is the most common reason people come to you, toothache or something is happening. Okay, intensely subjective experience. Why? You would have people that is very patriotic on the front line, okay, war zone, and they have been amputated because of a bomb, and they report that they don't feel anything. They want to go back out to support their colleague. They are the soldiers. You will have people that is very, we tend to feel that they are drama queen, like very exaggerated. They may not be exaggerating. It's just how subjective things feel. So IASP has given a definition: an unpleasant sensory and emotional experience associated with actual or potential tissue damage. I'm going to break it down into two parts. Okay, very important: sensory and emotional. Please don't undermine emotional. Sensory is the more real thing that's happening, but how psychologically impacted they are has a significant impact. It's also contributive as well. And second thing is actual or potential tissue damage. Remember, potential tissue damage, it doesn't necessarily have to be actual tissue damage already, or like, you know, any harm to us. It's a gift that we are given the sensation of pain, all right? And the reason is to avoid damage. Okay, there are actually unlucky people that are born without pain sensation, and they tend to get more trauma to their body as they grow up. They can fracture their bone or things they're not aware of. So it is a gift to have pain, and it is an alarm for us to be avoidant. However, specifically in periodontics, I use this very often with every single new patient consult. They refer to us, okay, they are stage 3 or stage 4, very severe periodontitis, but they don't believe the severity. They would typically say, I don't feel any pain, a little bit pink and red in the toothpaste or saliva when I spit it out, okay? And also, yeah, my teeth is starting to get a little bit wobbly, but I'm getting old, okay? So we always tell them it has, first of all, nothing to do with aging, okay? It is periodontal disease, and it's very severe. However, why do you not feel pain? We need to understand the concept of nociception. Nociception is pain sensation. So I would tell my patient, okay, we have a paper cut on your finger, it sting a little bit for 2 days. You know, unfortunate. We have a pizza burn. We ate pizza, or we ate something really hot without thinking. We burn our palate, and it's also sting. But guess what? 2 days later, no big deal. It's gonna be healed, right? However, do people go into the GP or the doctor and say, doctor, I can feel something growing in my liver. I can feel something growing in my colon, in my intestine? No. And in Australia, that's why the government subsidizes a lot. When people are 55 years old or more, every 3 years, they get a free bowel test to screen for it. Reason, different organs have different levels of nociception. And unlike the neighbor, which is the tongue, extremely responsive, okay, to taste and heat and burn, the gum is extremely non-responsive. So just because you're not feeling pain, and pain is not one of the thing we identify. Usually when patients present with pain to the periodontist, there's some form of abscess, and it's really, you know, if anything, very often it's quite terminal or endoperioral lesion. So this is where we educate the patient. Just because you don't feel pain doesn't mean you don't have problem, but for them to understand where we're coming from, this is the typical example I use. Paper cut, okay, pizza burn on the tongue, or do you go to your doctor and find out there is something wrong with your liver or intestine? Or are you usually told on the other end that, surprise, terminal? Okay, so this is the concept of nociception. Now we're gonna go through basic life support, because after all, after we talk about all the option that is on top of the topical and local anesthetics, like I said, you are always expected to prepare for the unfortunate. Not that we would expect it to see all the time, like probably in years we'll hardly see one, but it's that one case that you need to be prepared of. So that's why we have all this. So doctors ABCD follow the routine, okay, whether it's pediatric or not. So because this group is periodontic, so probably we see a little bit more adults or senior age than babies, but we go through the danger, responsive, send for help, check the airway, breathing, and be prepared with your CPR. If your practice have the defibrillator, that will be fantastic, although it's not compulsory. If you do have it, please ensure you're well trained of it. I just want to very briefly touch through on this. If you are going to take anything practical on board into your practice for my following discussion, okay? Make sure you are good with that. Terminology, we're going to go through a few terms and make sure our English is correct, okay? So there's no misunderstanding. Analgesia means the inability to feel pain. So painkiller is analgesic, all right? Anesthesia means something deeper. It means literally without sensation. Most of these words, obviously, as standard medical terms, they come from Latin. Now, anesthesia without sensation, it refers to a state of very controlled, temporary loss of sensation. Be mindful of control. So it's induced by us, doctors or anesthesiologists. So if someone just like lost consciousness, that's not anesthesia. So we will include some form or all of the pain sensation, which is analgesic. We will have paralysis, so muscle relaxation. They usually, depending on the depth, it can be completely depending on all the monitors and gear of the anesthesiologist to maintain their lung or cardiac function. We will have amnesia, so memory loss. Now, it doesn't have to be complete. So as you go all the way high up to GA, general anesthesia, obviously very often it's complete loss. However, it is very important at this stage. I make it quite clear. I will recap on it. Anesthesia is a spectrum. It's a continuum, okay? It's not like, oh, okay, GA, bang, that's it. You can also perform GA with other means of administration, but just be mindful. It can be very shallow, it can get deeper, and it can become a complete where they can be completely unconscious and rely on you to maintain all the other routine involuntary function, such as the pulmonary and the cardiac function. Okay, sedation is different. Sedation is just to provide a state of calm or sleepiness, okay? Do not mix it up with analgesic as well. Just because we sedate someone doesn't mean they have pain relief. They just sleepier, okay? They're just more sloppy and relaxed. And just because we give pain relief analgesic, okay? Let's say we give LA, we provide an analgesic, but the patient is completely conscious with us. Anxiolysis, okay, anxiolysis is using a single dose of oral. It's very often, so if you break it down, lysis means breaking down, anxio means anxiety, so breaking down anxiety. But it's just that very often we relate it to a single dose of oral medication. It's just that how we have practically used it. But if you relate back to the word, it doesn't necessarily have to mean oral medication only. It can be anything. It can be gas. It can be anything that we treat the anxious patients for by breaking it down for them. Okay, so let's get these terms right, because later on we will be relating to this, and it's important that you don't mix it up. So for pain and anxiety management, what's our option? Now, I'm not gonna be going too far into the topical and local anesthetics because you will all be familiar with it, but this is more a hierarchy going up. So remember I said we ask our patient 1 to 10. So if they report 1 to 2, okay, usually you know they will deal quite well with the topical and local anesthesia. But anything 3 or more, we will dedicate a significant time in addition to the standard consultation, telling about their gum, their teeth, why it's falling out, why it doesn't hurt them, but there's actually severe problem. We will also spend some time talking about the different pain and anxiety management option. So oral sedation, we will cover the medication that is typically used. Remember, it is sedation only, so it does not provide pain relief, and that's why it is a plus. It's going on top. We still have to have topical and local anesthesia. Oral sedation is just an add-on. Alternatively, we can do inhalation sedation. Okay, inhalation sedation is much more controlled. The beauty of it is it has much less side effect. Okay, so oral sedation obviously is adding side effects on top for the treatment. IV sedation will also do that, and also GA. However, inhalation is actually considered the safest one. All right. Higher up, we have IV sedation. So there are dentists that can be particularly trained for it to monitor it as well. In Australia, for any dentist that have done a particular graduate diploma to administer IV sedation, they can't be the same dentist to do the dental treatment. So let's say I'm a dentist and I have a graduate diploma for IV sedation. I can't do the IV sedation and do the filling. Okay, I can either be the person sedating, or I would just have to be the dentist. So in my practice, because we're specialists and we would prefer to work closely with our specialists, we usually invite the anesthesiologist to come in to monitor the IV sedation. Highest level is general anesthesia. That obviously is bringing it up into a higher level of gear. Usually it's in the operating theater, so we'll cover that as well. Now, as the hierarchy go up, there are a few things that go up as well. So the cost goes up, the training requirement goes up, and the technique sensitivity. So I believe with you guys, it will be quite similar with oral sedation and inhalation sedation. It's covered in your dental registration, but when you come to IV sedation, GA, they do require extra training, and GA, basically, it's out of our league. It's something about we work with, but we're not going to administer. You will require anesthesiologist. And obviously, as all of these go up, technique sensitivity is there involved as well. So just to run you through, if you do start implementing your medical history with the question as in where the anxiety level, so oral sedation will benefit the patient that is 2 to 4. Anything higher than 4, I would, go through the inhalation sedation, IV sedation with them. IV sedation quite often can cover all the patient that reports up to 10 as well. Okay, so GA is a level that is not just for anxiety. It's more for the medically sick or extremely retarded patient that we can't communicate, they wouldn't open their mouth for you. So I'm going to go into it because GA, apart from cost involvement, a lot more side effects is involved as well. So we very much try to, if it's due to anxiety, if the patient say, "Doc, do anything to me but knock me out," IV sedation is usually the one we would like to consider to work with the anesthesiologist together. Okay, so oral sedation, let's start with the first level, okay? I expect you all to be quite competent with topical gel and local anesthesia already. Just to add one thing, topical gel, the application, okay? So if you remember the pain sensation, so that is A alpha, A beta, and then the C fibers, how the afferent nerve go up to the nerve. So when you apply the topical gel with the cotton bud, I always recommend when we teach the dental students or peri students, apply pressure as well. Okay, if you put the gel on the mucosa, you're relying on one thing, chemical reaction, right? It goes in through the mucosa and numb it a little bit. But you can also do another one, which is more the mechanical one. So when you put the cotton bud and actually apply pressure to the area that you're going to be injecting to a point that you can see blanching around the area, they're not going to hate you. They're not going to feel it's, it's going to hurt because it's just pressure point. But then right after you remove it and put the injection in just, a millimeter or so, the sharpness, they may not be able to respond fast enough to sense it because they are still activated by the fiber to sense the pressure point. And this relates to, remember when we get mosquito bites and it's itchy and you tend to scratch it, so it feels less itchy because you are stimulating the scratching sensation on the side, and it loosen and ease the itchiness sensation. So it's just by activating the fiber next to it, okay, that is pressure point, you inhibit the activation of the fiber that trigger the sharpness sensation from the needle. Okay, so now we're going to go to oral sedation. The most typical one is diazepam and lorazepam. Diazepam is slower acting. Okay, they both GABA transmitter enhancer. What does that mean? So GABA inhibitory neurotransmitter, basically when more of them is released, it produces a sense of calmness for your patient. Diazepam has been around for years. They were just very often advertised as under the brand name Valium, and lorazepam is under the brand name of Ativan. Now we tend to use lorazepam a little bit more now. However, be mindful of the different interactions and scenarios. I'll go through it with you as well. The reason we use lorazepam a little bit more often is because it's faster acting. Okay, so it will take a shorter time for it to kick in. So you can just give it to the patient, and in 15 minutes or so, you can start, topical gel, local anesthetics, and ease it in. Whereas when you give diazepam, you usually have to ask them to take it at least 1 hour before the appointment, and it can take up to 2.5 hours to reach the peak level. Now, when they are slower acting, it's also gonna take them longer to go away from the body. So the half-life, depending on individual liver enzyme activity, it can go up to 100 hours, and it's just half-life. Whereas with lorazepam, the half-life is about 18 hours. Okay, so the major difference is the faster acting. It comes in different dosage, so they can come in tablets of 2, 5, 10 milligram for diazepam, or 0.5, 1 or 2 milligram for lorazepam. Now, how much should I give my patient? If I'm giving a diazepam, it's very typical that my script will say 15 milligram. So I will say 5 milligram times 3 tablets, or 1 10 milligram, 1 5 milligram tablets. And I will instruct my patient to take 10 milligram, so 2 5 milligram tablets, or just 1 10 milligram tablet 1 hour before the appointment. They have to come in, they have to present to me with the last tablet of 5 milligram. And at that time of presentation, I will observe how well sedated and comfortable they are. If they are reporting to be quite comfortable, I will remove the last 5 milligram for them. But if you see that they can benefit a little bit more from that 5 more milligram, that's when I give it to them. Okay, and as for lorazepam, we'll be using around 5 milligram. When you go to 5, it's quite high already, and you should be able to achieve a really good result. Okay, it is important when you do oral sedation, they must be accompanied by responsible adult, and they are advised that for the next couple of days, especially for diazepam. Lorazepam, usually they just need to rest for the rest of the day, let the wife or the husband do all the dishes, cooking, looking after the kids, and tomorrow they will be ready. Okay, but the diazepam can take longer, so it's mindful that they can't drive, no mechanical machinery, and more importantly, no financial decision as well. Now, apart from the fact that lorazepam is faster, now everyone's going to go, oh, okay, then I'm just going to do lorazepam. And not quite, okay? So we need to look at the different timing of what we're using as well. So before you prescribe any drugs, you should be quite familiar and read up your memes or your pharmacology book to understand the interaction with different medication anyway. However, I would like to name a few that is commonly coming across in periodontics so you guys can be aware of. So if people are on long-term diazepam and lorazepam, they can have some interferences with the depression, okay? In particular, lorazepam. lorazepam can trigger more depression scenario. So if a patient is already reporting depression, you may be more careful in not giving lorazepam and give them diazepam. However, they all interact with some level of antidepressant. They all interact with opioids. Now, with periodontics, unless you're doing huge GBR implant and all that, and like a periosteal relieving incision, raising the whole flap and loosen it, I believe with a non-surgical or even some standard perio surgery, patient can benefit well enough from a combination of Nurofen or paracetamol, so ibuprofen or paracetamol. If you think the patient will be requiring Panadine 4 or some level of codeine or opioids, you need to be mindful because there is reaction with opioids as well. Another thing that comes across is diazepam, okay, which it doesn't apply to lorazepam. Diazepam has reaction to erythromycin and clarithromycin. Now, although we don't have the study for me to pull it out and put it in front of you yet, some of you may be quite familiar with the new drug azithromycin already, okay, that we quite often can use together with periodontal treatment to achieve a good result. If you are considering azithromycin, I will be a little bit careful with diazepam as well. Why? Because azithromycin belongs to the same family of erythromycin and clarithromycin, right? And although with all these studies, it takes time for them to test them out and say, okay, that's this interaction. So I don't have something that say it definitely have interaction with azithromycin, but we know diazepam has interaction with erythromycin and clarithromycin. So if you want to consider azithromycin, please try to stay with lorazepam then. Okay, we're going to go to inhalation sedation now. All right, so remember the costs go up. So obviously having some tablets, it's a little bit cheaper. Next up we have inhalation. I'm going to cover 2 of them and I'll let you know which one I use most often. However, these are very accessible here. So the first one is the Panthros. Usually we call it the green whistle on the ambulance. So what is the active ingredient? Methoxyflurane. It's very fast acting. For those that's not familiar, it comes just exactly as the picture you can see in the slide. It's a green whistle and you can see all these little charcoal up there. They are the activated catalyst and your medication come in the little bottle. The way to use it is you have to open it and tilt it into the catalyst, shake it for a little bit to activate the medication. Then the patient is usually asked to hold the green whistle and blow in and out of the whistle. Now it's very important. It doesn't matter whether it's Panthros or the next inhalation option we're gonna go for. Any inhalation sedation, please tell your patient breathe in and out through the same place. Okay, don't breathe out. So if they are breathing in through the nose, breathe it out through the nose. Again, don't breathe that out through the mouth and share everything with the practitioner. And if they are breathing in through the green whistle, they also have to breathe out back into the green whistle for it to be removed. Now, I personally don't like Panthros that much because it's a really pungent smell. It does provide some level of sedation as well, but very low level. The main reason of use is to reduce pain. So it's more an analgesic. It's to reduce pain from trauma. And that's why they always have it prepared on the ambulance. If there's suddenly, a big car or big drama with a patient that got onto the ambulance, this is the first thing they give the patient to breathe it through. Be mindful of the path of administration. So this is coming through the mouth, okay? So different to the next one, which is going to come through the nose. So when it comes through the mouth, it means halfway through you drill a little bit, you have to stop, or you have to clean 3 teeth and you have to stop, but you have to let the patient breathe through. So the way to work is initially you ask them to breathe through 6 to 10 deep breath. Deep breath means I have to see their chest moving up and down. Afterwards, every minute or so, they may have some dose up and have another few breaths. So they get the relief and then you continue the treatment. So this is a little bit annoying as well. Apart from that, smell actually smell horrible for the patient because they keep needing you to stop and letting them breathing that in. I believe it's all periodontist here, but for if there's any chance there's dentist involved, and if you are going to be using rubber dam, whether it's for filling or root canal treatment, obviously consider it that this won't be an option for you. So it comes in 1.5 ml or 3 ml. Usually within a day, you can use up to 6 ml as the maximum dose. If the patient has not finished the medication after the appointment, do not give it to them, please. Do not give it to them. Any of the medication that we're going to run through today, except probably the next one, you wouldn't want your patient to take it home and party with alcohol. Okay. Now, next one is relative analgesia. Okay, some of you may have been familiar with nitrous oxide sedation already. So that's another inhalation option. It's quite different to penthrox, and it's also known as relative analgesia because it doesn't only have the beauty of being sedative, okay, it's also an analgesic. It provides significant pain relief. So there must be a lot of ladies in the group right now, and ladies who may be quite familiar. I don't know if you do the same thing in India, but all pregnant women delivering babies, first thing, mask up. They give them the elephant trunk nose so that you're breathing in this gas. This gas, compared to penthrox, which smell horrible, it's a sweet smell. Okay, it's a sweet, little light, sweet, fruity smell. And when you breathe it in, apart from just sedating you, it provides significant analgesic, so pain relief as well. And that's why it's quite often people just deliver naturally with the baby, just breathing through the gas. Okay, and the fact that they use it for childbirth, what does it tell you? Super safe. Okay, compared to all the oral sedation and the other medication we're going to cover through later, this is probably the safest sedation option here. But it's kind of in the mid-range. Remember the little pyramid, so the cost is involved as well. Obviously, we have to purchase the nitrous oxide and oxygen for the patient. So with nitrous oxide and oxygen, they are used together via titration, okay? The goal is to maintain verbal contact with the patient. They're not supposed to be fully sedated and knocked out. If you ask them to open their eyes, they should be able to, but usually we don't because the light is there and they can just close their eyes. We usually ask them to close their eyes, but then we'll ask them to open their mouth to the widest, close it, open to the widest, and close it. If they do it super quick and like very conscious, I don't think you are having them really well sedated, but they should be able to respond to you still. Okay, and they are able to respond to light tactile sensations. So if you tap on the shoulder, they should be responding as well. This medication and so the technique is not very difficult with the use of it. If anything, it is the equipment's preparation that is a little bit more cumbersome that I will show you later, but to manage it, it's quite easy. So like I said, it is a titration of oxygen and nitrous oxide. The maximum dosage of nitrous oxide you can go to is 70%. That will means you have a 30% oxygen titration there at the same time. Do not judge people by their size. You know how when you give medication like oral sedation, you usually calculate, okay, how big is the baby, look at the kilogram, how heavy it is, do your mathematics calculation and give them the dosage. It is different with nitrous oxide. Do not judge them by the size. You can have a huge obese guy and you only need 15% of the nitrous oxide and they're feeling quite well. And you can have some skinny young Asian lady, very tiny, they are very anxious, they need 70%. So we're gonna go through how you're gonna judge them clinically to know you have achieved the optimal dose for you to commence dental treatment, but not overdosing, obviously. Now, there are many other common terms around. So relative analgesia, nitrous oxide gas, they are also known as happy gas, lava gas, psychosedation. Okay, so we'll go through that. And just a quick little video, if you guys haven't seen this movie before.
You said Dale, start the gas. Dale starts. You said Dale, start later. You turn that off. Turn the gas. Right? Brothers. Are you kidding me? It's like a billion times. No, see, you're just like it's not doing it. Let's get the fuck out of here. Daddy, what are we talking about? We're outside. Stop here. Get the fucking camera out. Don't start laughing. What is this? Did you have your face? Yes. Yes. Yes.
Okay, so for those that haven't seen this movie before, it's just from Horrible Bosses. They are just a comedy, but that's not the main point. Main point is I want to demonstrate how fast it works. Okay, within a minute, your patient would usually be able to achieve the level of relaxation. So they become really cooperative, and it's not uncommon that they start laughing at you exactly the way it is in the movie. The problem in that movie is that obviously the gear is not right. There's no mask, and exactly my point. If it's not properly set up, it can be shared to you and your dental assistant, and obviously that is not what you intended to do. So make sure the gear is well prepared as well. Okay, so this is one of the most common pharmacological management for dental patient and especially pediatric patient. Nowadays with the pediatric dentist, not every babies have or like kids have to go to GA. So whenever they can, they usually consider nitrous oxide and they become very cooperative. Now, what would you get is a patient that is extremely anxious of needle, let's say just needle in particular, they will say, after you achieve the optimal dose and you say, okay, my needle is coming in, they usually go, yes, please, give it to me. So this is where the difference is. But the beauty of it is very fast acting. The reason it is very safe is because the coefficient, if you remember your pharmacokinetics and all that, the coefficient for it to transfer through the BBB, blood-brain barrier, is very it's very low. So it doesn't go through to the brain. It's just maintained through the system, through the lung, and just relaxation. And that also means recovery is really quick. So like I said, it's a titration. Nitrous oxide and oxygen will have to add up to 100%. So it's either way, it will be 100% together. Optimal dose varies between individuals, so don't judge them by their size. The maximum dose you can go to is 70% against 30%. You are not supposed to mix this with oral sedation. Okay, so if it's oral sedation, it's only oral sedation. If it's inhalation, it's only inhalation. If it's IV, you do not try to mix things up. But as a monotherapy, so if you only use nitrous oxide, it's very, very safe. Okay, and it's just very commonly used. The only thing is the cost for your dental surgery or periodontics practice to have it equipped and set up. When it is combined with other agent, it can become a GA level. So remember, I did mention from the beginning, anesthesia is a continuum. It's a spectrum. It doesn't mean, okay, here is, you know, this level of sedation, shallow sedation, twilight sedation. It's not, these are just terms of English. As long as you understand all the terminology of the A letter that I've explained to you, you can do a combination of oral sedation, gas and all that, and then achieve GA as well. GA just little meaning you have achieved that level of unconsciousness, but it can be through any drugs. It can be through any pathway of administration. Okay. So we're gonna come to the beauty of it, like what is so good about it and why our practice is equipped with it in all the surgery. It's very fast onset, so any patient come in and they will benefit from it, and you can always turn it off right away if the patient is only scared of needle. If they are numb and they don't need it anymore, and you know you're gonna spend 1.5 hours doing the non-surgical peri-debridement, you can turn up, make them comfortable, needle in, and then when they're done, they're nice and numb, you can recover them and put them through 100% oxygen again. Okay, so the way to work is always turn on your gas, when the gas is already running through the mask, you put on the mask to the patient, and then you start titrating the medication up to an optimal state. And then when you finish, you have to put the oxygen back to 100% to bring them back to full consciousness, and then you remove the mask. You never turn any gas off with the mask on their nose. Okay, so rapid elimination, it's very easy to administer. Later on, after these slides, we will be going through the equipment and how's the setup. Actually, there is very minimal interferences with dental procedure because it's a nasal administration. We're not going through the mouth. So you can do, you know, have your time, do your own thing, and it's just gonna go through the nose step. It's very easily controllable though. So it's when you have the regulator, you can just be tuning it up on your digital regulator there. And I'll show you through all that. It's very safe when you do it properly. When you instruct the patient to breathe in and out through the nose. Do not let the patient to breathe in through the nose and breathe it out through the mouth, okay? Because it can be shared to you and your nurse. Freedom from hangover, low cost. So compared to all the other options going higher up in the pyramid, the cost of it is considered very low in contrast to those, and it can achieve a equivalent and very good results. That's why it's very popular as well. Now, there is a significant reduction of dental procedures, memory, and the requirement of local anesthetics. So I can very often have patients that have nitrous oxide gas, full mouth non-surgical debridement for 3 hours, pockets up to like 8 to 9 everywhere, did not have a single needle of local anesthetics. Okay, so that is achievable. Obviously, this is not a promises that I want you to give your patients and go around, but usually when we run the gas, you realize they have a lot of reduction in the need of it. So the fear, anxiety, apprehension of dental treatment or fear of needle is quite common. We had patients back then before just because I did the oral facial pain management a little bit as well. So I had a patient that has a very strong masseter and temporalis that is heavy grinder, very stressed. He's actually a rugby guy in Australia, play sports. So we have to put some Botox in, and he's really scared of needle. So we just run the gas, put the Botox in, and reverse the gas. So needle, fear for needle is a very good one to use. Okay, there is decreased tolerance to dental treatment, patient with muscular disorders. This is where it brings to the gag reflex as well. So because it significantly relaxes them, if you have a patient that have a hyperactive tongue, you know, we all hate those patients, fighting for space, or suctioning, moving around, you know, coming into my place, and you keep telling them, relax your tongue, put it down. This is a beauty. It really stops them. And the other one is the gag reflex, because the reflex is significantly retarded as well, or be inhibited, so they don't keep choking on you and keep trying to swallow the water. Mentally retarded patients must be the cooperative one. So for all mentally retarded patients, we separate into two, cooperative or non-cooperative. Okay, so you can have really, really nice patient that has Down syndrome, and they're very cooperative, and you can benefit from this. But you can have the other end that's you can't even look inside the mouth, and those are quite different. Those very often will have to put through IV sedation or GA. Now, children with a minimum age of 4 years is required, not so much for us as perio, but just be mindful, any younger than that, you know, although there is perio, it will be a cooperation between us and the pediatric dentist. And it must be cooperated with nose breathing. If a patient come in, like, honestly, at this time, if they come in and they have a flu, a blocked nose, probably we should all send them home because of COVID to be really safe. But let's say a patient come in and, you know, there is no patency through the nose, and they say, oh, when I lie down, I can't usually breathe with my nose very well because I'm a heavy smoker for 30, 40 years, and They also have COPD as well. These are the ones you have to be considerate. Like, you know, this may not be an option for them because you need the nasal pathway. So remember Penthrox, we use the oral one, and for nitrous oxide, we use the nasal one. So let's just quickly go through the setup. What are we expecting? There is nowadays 2 forms, portable. So on the left-hand side, you can see a trolley. Green and blue. Blue is always the nitrous oxide. Okay, it's the tank of nitrous oxide. It's a universal color, so wherever you go, it's gonna be blue. The green one is oxygen, and it's only in America. I think in Canada as well. In Australia, our oxygen tank is white. So my portable trolley is white and blue. Okay, in the middle there is a little flashback. We can see a little balloon. So when it pumps out, especially when you need to recover the patient, so you can squeeze that and just pump the 100% oxygen as well to push through and bring them back really quickly. We do say, you know, like 1-2 minutes, patient will be ready. So if you want to like follow guideline, just give it 5 minutes. But seriously, it's very fast acting. Okay, if you if it's a patient that doesn't need really high dose, if you put them on 70% 2 breath, they are ready. Okay, on the right hand side is a wall mounted option. So this one, the setup will be quite different. Then you will have much more space in your surgery to do other things, because with the trolley, the portable one, basically it sits behind the patient's back, okay, behind their head, and between you and the nurse. So it takes up quite a lot of space, to be honest, but obviously not all practices are equipped with it. With the one that is wall mounted, usually it's just in the cupboard. So it's piped up throughout all the surgery. So in all surgery, you just open the cupboard, put a regulator up, and you have it handy. If you look at the regulator on the left one is the new one. So it's a white box with this green letter. So it's just a digital marker, and you just regulate the oxygen and the nitrous oxide level. And other arrow up and down is the flow rate you will have to regulate as well. Okay, so flow rate is usually 5 ml per minute, and you can use up to 6, but 5 to 5.5 usually is significant enough. Okay, and then on the right hand side, you can see it a little bit different. There is 2 little, I'm just going to move my mouse, hopefully you guys can see. So this is the digital one. This arrow is to control the content of oxygen. So by saying moving oxygen from 20 to 30, you will know your nitrous oxide is going to be on the other side and adding up to 100. So you only need to control 1 gas. You don't need to control 2 gas because it's always going to be 100%. This is the flow rate. So it's now like 5.0, if you can see, and it can go up to 6, like I said. You don't need any more than that. Otherwise, you're just wasting your gas. This one is the older one, the older regulator. So it has a little ball there. One is obviously nitrous and the other one is oxygen. So when as you regulate it, it will just go up to say 40% or 60%. So you can use that as a regulator. But honestly now, there is very rarely people use this now. They all go with digital, which is much more accurate. And this is the flow rate regulator, okay, to whether it's 5 or 6. So this is the old one that I mentioned before. So nitrous oxide, you have a little ball that flow up to the level and go up there. This is just a different model, and you can regulate up here. Okay, and this one, the knob is usually the flow control. This is the digital one. It shows you the oxygen percentage here, and that will mean 100 minus 65. So you will have your 35 of nitrous oxide going on. The flow rate is 40 here. I always start with 50. I just find it faster and more efficient for my daily run. And if you see it's sufficient, I just keep it at 50. It's very rarely I have to increase it and regulate, unless you can see this guy with big chest and large lung volume. Okay. These are the regulators. So this is the oxygen one. Remember, nitrous oxide is actually a liquid, okay, whereas oxygen is a gas. So the gas is very accurate. So when it's full, it will be here. right, at the green bar. And then as it go down by proportion, because it's by the pressure in the tank, it will just show you as it run low. So if it's here, it's very accurate. You still have a quarter left. Okay, it's a little bit, accurate, but the nitrous oxide is different. It's like your gas. You know how you drive your car, and then it will initially stay on full for 2-3 days. It just stay on full for a long time, okay? And then suddenly it comes down. But the lower it goes down, the quicker it goes down. So it will stay here, okay, for quite a long time. Multiple patients you can use, and then when it start coming here and then going down there, super quick. Okay, because it's a liquid, so the meter in checking the remaining content is not as accurate. So be mindful, as long as it go past 2/3, we usually will tell people to be prepared and getting new tank ready and get the extra tank ready. This is the old one. This is how it works. So on the back, this is the elephant trunk, we call it, because it's very big and bulky. And just look at this picture. There are many different options of masks. So the old one is autoclavable mask. You will be removing this blue part and putting it into your sterilizer, and every patient can use it. Obviously, they come with 3 standard sizes only: small, medium, large. Okay. Now, what is the problem in this picture that you can see? Number one, this trunk is really big and bulky, so you can't make it hook up the ear. So it always collapses just under the zygoma, and it's annoying because when something is here, when you work on the upper and look at the mask blocking completely your 1-1 and 2-1, and you're trying to do a debridement or surgery there. So this is the old one, and I'll still run you through. This is a disposable scented mask and very often used for kids. So they just have, strawberry, vanilla smell, different sizes, which you can just dispose of rather than the blue one. The autoclavable either come in blue or gray, and they obviously much more expensive, but then it's just standard sizes. With the scented one, there is much more different sizes, and it's pleasant for the patient as well. Or however, because it's scented, you can't tell whether the patient is really having the gas and there's the flow already. With the autoclavable one, you're just smelling, rubber, right? And then when they start smelling the sweet smell, the gas is running. And it's common that I ask them, can you start smelling something sweet? But if I use this mask, I'm not able to even ask them. They would just be like, I'm smelling strawberry. Now, this is a new one. This is a lovely one, and we love it very much. It's a little bit more skinnier, clear, okay, and it can seal the nose. So right here, there is actually a strip on the back, which is like just little sellotape that you remove. And after you remove it, can you see here, there is the 2 little knots, okay, that will just fit into the patient nostril. So you can make sure this is complete seal. With the previous mask, this one and this one, there's no complete seal. There's definitely spacing here, okay? So even though if they are breathing throughout the mask, you can still have a little bit leakage, although it's insufficient to really bother you and your dental nurses. The main problem that bother you is if you are running on 70% nitrous oxide, running on 6 ml of the flow rate, and then the patient is not stop breathing out through their mouth and not listening to you. Okay, so with this one, it's much better, much more accurate, because it's completely sealed off for them only, and it's carried away with the scavenging system. And I love it so much because this is so skinny. When it's skinny, you hook it right up here. It just line across here through the ear so that it's completely out of your pathway. And this U-shaped thing, okay, so this U-shape here actually will lift it up and hold it up against the nose so that you have much more patency to access your upper anterior for treatment as well. This is just to run you through basic and other equipment that you don't use. So apart from the portable gear, and then you will have either digital or standard regulator. Okay, you will either have the elephant trunk, the big white one that is with the old mask, or the new clear mask that run through. You also always have to have this blue bag ready. It may be different color in India, but you need to have this emergency bag ready. This is just another tank of a smaller oxygen, and then it has the pump when you need to resuscitate patient. We never use it, but it has to be in the background. These are the new oxygen tank. It's so the new oxygen tank. This one is called TECO. And what is so great about it? It's so accurate. Instead of looking at that bar, you know, like that needle that coming down, like, oh yeah, I'm nearly finished. It actually will tell you exactly what's the volume or the content of the oxygen is, and most importantly, this is what I love. It will tell you how long it will last. It will tell you how long, like it will last you another 3 hours. It will last you another 7 hours based on the flow rate that you're giving. Okay, it's a little bit like GPS. So at the speed you're driving, and it will tell you, okay, it's going to be 2 hours before you get there. Now, next thing, this one, please always have an oximeter ready. It is not expensive, but I believe just, you know, even standard dentistry or periodontics, it doesn't matter. You know, like you have a patient that have a heart condition, let alone sedation. Even if you're not doing sedation, there's no harm to just clip it on the patient and monitor. Obviously, we all know that if it's below 90, you have to be more attentive. And if we are running nitrous oxide, oxygen, it's quite clear that you want to monitor it. So anything above 90, you don't really need to be too concerned. But if it's like below 90, you have to be a little bit more careful. Okay, the capacity of lung usually is slightly compromised if you're running the nitrous oxide, and it's not uncommon. You look into it, and there's like, oh, of course, you know, lung cancer, severe lung problem, half of it being cut out because of past smoking or something. Now, clinically, when do we stop? So do I go to 70%? Do I stop at 60%? Where do I stop? What are we looking at? Physiological changes. There will be decreased pulse rate. So that's why the oximeter is beautiful, because it's very instant. You can just watch the numbers going up and down. There will be decreased oxygen saturation as well. Okay, it can go down a little bit, but like I said, as long as it's above 90%, you don't need to be too worried. And then they will have reduced nociception. It's not uncommon they report tingling. Now, it's very individual though, so I don't want to exclude it, because there will be patients that tell them they feel so relaxed, they are floating in the air. You will also have patients that will say, I'm so relaxed, I feel like I'm completely sink into your chair and melted with it. Okay, so it can have a little bit differences, but these are the reports. So you look at 99% will report that their eyes become brighter, like all the light looks so much brighter than me. Not that we ask them to open their eyes. Their voice will change. You can notice their voice becomes so much more toned down, relaxed. Okay, the man will become the voice will become more magnetic, just lower. They will start smiling at you, quite, you know, just involuntary smiling, or if you say something, they just start laughing, like the video we have shown before. And reported tingling. Tingling is usually reported at extremities, so fingers and toes. They will feel a little bit like, oh, they're a little bit tingly and numb. Now, what is the extremities in our area? Papilla. So papilla is our extremities, and this is why in the period pockets area and all this, when it's quite common that I can do non-surgical treatment for a very severe patient with periodontitis without injection, because, you know, the extremities is where it take on the most analgesic from nitrous oxide. Okay, so just be mindful of that. Reported to feel relaxed. So these are the things that you will start asking your patient. Remember, they are conscious sedation, so they still with you. They are just more relaxed. But you don't have to, obviously don't start putting heavy rock music in the background. I don't know about you guys, like I put on music all the time. I start playing some relaxed jazz. We'll turn the light down. In my surgery, our light is not just on and off. We have a dimmer. We turn it down, because all I need is my loops light and the headlight anyway. I don't need the room to be very bright. We help them to get relaxed, because they will feel like even their eyes is closed, they can feel like there's some bright light there. Put your sunnies on. And what else? I think the volume. So sometimes it's very funny when I first saw some trainee to administer nitrous oxide. they are not in a different zone. Okay, they just more relaxed. So you don't have to talk slower to them. You don't have to just talk normal. Okay, they already feel like that, and you don't have to yell at them. They're not deaf. Okay, I have seen new young registrants start yelling at them like like, can you hear me? And this is what's going on. I'm going to start now. It's unnecessary. Okay, please don't do that. It's a calm environment. Just like, I'm gonna start now. You look very comfortable and ready. Just pretend you're at the beach with your sunglasses on, and that's it. All right. Don't start yelling at people when you're sedating them. All right. The signs: intact response to verbal command. Okay, so if you talk to them and just say, how relaxed is that, and they should say, yeah, it's pretty good. If they don't respond to you, maybe lower the dose a little bit. Okay, so we work by two ways. Okay, one is called incremental increase. Obviously, for all new patients, you will start with that. So right away, from 100% oxygen, I'll tune it down to 90%, and then 30 seconds later, I'll become 85% and keep going. So in 2 minutes or so, you should have achieved your really good dose when you observe what we have discussed. Okay, and when you ask them, are you feeling quite relaxed? Any tingly response? And they say, yeah, that's it. You stop. Okay, this is option one. Option two, which I love, okay, when you start seeing this patient again and again for the SPT, or like every 3 months for another clean, but they still very anxious. Obviously, you're gonna put notes in your clinical notes. You're gonna say, okay, optimal dose was achieved at 45% nitrous oxide, and then 55% oxygen at a flow rate of 5.2. So what I usually do is I will go straight to 40%. Okay, just 5% less from the optimal dose. Go straight to it. I don't need to waste time incremental all over again. I go straight to it, 40%. Observe her feeling quite good. Just add back to that 5%, and I know that is her individual optimal dose. Okay, and this optimal dose for this individual doesn't really necessarily change intra-individually. Okay, so there's significant inter-individual differences. Like I said, big guy can have little bit and it's sufficient. Small guy need a lot. But if you have achieved 45 in the future, most likely it's also 45. Just by changing your procedure doesn't change that. Okay, so last time I was doing non-surgical. Today I'm gonna do an open flap debridement. Does not change that. Okay, you are still providing the local anesthetic for pain relief as indicated. We're talking about sedation here. All right, so apart from being reported to be relaxed, comfortable, general reduction of spontaneous movement, the mouth is kept open on request. So you know how there are some annoying patients that you keep cleaning and the eyebrow is itchy, my nose is itchy, my eyebrow is itchy, my nose is itchy, again you keep scratching and they keep interrupting you. So when they're sedated, they will less likely to do all these things as well. There will still be a normal laryngeal reflex. What does that mean? They can still swallow. They, you can suction, but you can still tell them swallow. It's very funny. Like I just find it like, because we see Australian here, and obviously we also have special ethnic groups. So we see Chinese or Asian, and we always have this joke: the saliva or the saliva is their saliva. They can swallow it. But once they are in the dentist chair, their saliva is not their saliva anymore. They can't swallow it. They have to spit. I don't know why. And you have to suction it. So it's sometimes we just, encourage them. They can still swallow. Make sure it's okay that they understand they can swallow. There's nothing wrong with it. The beauty of it is the gag reflex reduction. You will realize the tongue just stays very calm there, not flicking around and fighting with your nurse for the suction. Now the blood pressure should be normal. The respiratory rate, heart rate, skin color should be normal as well. And you will be observing the oxygen saturation level with your finger oximeter. Now symptoms of reported that is more afterwards, that this is what patient will tell you, because during then they usually quite relaxed rather than reporting. So they can say they can feel tingly in their fingers, mouth, feet, tongue, remember all the extremities. There is a feeling of warm sensation. There can also be report of feeling of cooling sensation. They can report to be dreaming. So I have patients that have a lot of funny dreams that they will start sharing with you. They will have different passage of time and surroundings. So remember I said it's a little bit like those sci-fi movie. They will feel like whoa, the light is going past me and everything, like what, like they will think, remember you and your nurse were talking very slowly. They feel like that, but obviously that's not the case. They will feel a little bit happy, euphoria, physical and mental relaxation. They can actually hear you quite well. They can, it's like their eyes are brighten up, their ears are like open up and all that. They can hear you quite well, but whether they remember what you say is in other things. Okay. Lowered awareness of pain, we have already talking about it, and floating and drifting or detachment. So they feel like they can be in a different zone as well. Now we have talked about all the beautiful things about nitrous oxide and why we use it so regularly and daily for patients. We also have to be aware of the risk. Although I did say many times the side effects is very minimal and it's a very unlikely you have any drama, and even if there's a complication, it's easily manageable. Whatever happens, put the oxygen back to 100%. Okay, so what you can have is depression of protective reflexes. Okay, and then so what is protective? All reflexes tends to be a little bit protective. So for example, the tongue, the gagging reflex is to prevent them from choking and something going down the wrong way of the epiglottis and going to the lung, right? So all the reflexes are slightly retarded. There is individual response to the drug. So children, elderly will respond a little bit differently, and we have to be aware of the pre-existing medical disease. So be mindful if patient have some psychotic condition, sedation is something we'll leave it to the anesthesiologist whether they will decide to do IV sedation or not. Now for male practitioner, I would recommend you to ensure your nurse, your staff is always there. You are not alone in the room with the female patient, and also it will be good if your nurse is female as well, because although extremely rare, there are reports and there are patients that felt that they have been when they wake up, they were like, whoa, did you remove all my clothes? Okay, they just felt a little bit sexually aroused, and it can happen. It just tends to give them pleasant feeling, but obviously which direction they go is unpredictable. So if they feel sexually that way, it is safer for medical legal reason and just to protect yourself as well to have a female in the room all the time. All right, differing standards of equipment and staffing at the location. So depending on your surgery setup, occupational hazards. So it's reproductive. So there are some cases reported. Now, these are case reports, okay? We're not talking about systematic review or anything like that. And these case reports are very often associated with the 60s or 70s when the equipment is significantly more substandard. And back then, what happened is they just have gas running, just more or less like the movie rather than have a mask. And there were dental assistants that was pregnant and had stillbirth or lost the baby. So this is where these reports come in and has commented on nitrous oxide can have an impact on the reproductive. But the reports of it is very often insignificant. However, it is as a practitioner, it is our obligation to be mindful if we do have staff or patient that is pregnant. We will have to consult them and advise. There are case reports of such, although it's still very safe. There must be informed consent. Okay. Liver, kidney disorder, standard, organs that you need to remove drugs. So if there's anything that is concerning, then you have to be mindful. Nausea and vomiting. Vomiting is extremely rare, but you can have reported nausea. So about 10% of the patient that have nitrous oxide will report some level of nausea. And this is where we always get some antiemetic ready. So Maxilone is a little bit too slow and not strong enough. So usually what do we have that is working quickly? Ladies again would know very well when you have morning sickness, Ordenastrone. So little tablet, sublingual, okay, put it right under so they're still happy, they're not feeling nauseous, they just relax and you doing your job, okay? That dissolves obviously quite quickly. All right, gonna keep going, otherwise too much content, we're gonna overflow. Contraindication, nose, and upper area, okay? If we're not gonna be breathing through or lung and all these have bronchitis, all these problems, then forget about nitrous oxide. Dental procedure that's interfering with the mask, it's less of an issue now because we have very new design of masks around available. Severe forms of systemic disease. To be honest, we will go through it in the case scenario later, but when you have a really sick person, 98-year-old, 20 medication, 10 medical condition, seriously, please consider a higher level of anesthesia for them to be more comfortable and safer as well when you commence some significant dental treatment or periodontal treatment. B12 or folate deficiency, so it is very minor, and again, like this is more common for people that's already running low on it. Okay, it's not going to have a huge impact. It's just that they may want to be mindful whether they want to take vitamin supplement or have some meat afterwards, red meat, or in India a lot of people are vegetarian that have more green leaves. Okay, pregnancy, we have talked about it already. Hernia, internal hernia. Okay, so because your lung can't move as well, it's very often like a scar tissue. So ultimately everything relate to, all the sedation relate to relaxing, so it's a mental state. So consider any psychotic condition like psychotic patients, and also consider the airway. These are the two main things. If you forget everything else, please remember pathway of administration and patients whether they have depression. So when you treat anxiety, you don't want to compromise the depression, because patients that have these, they usually have them together. Okay, conscious sedation. Now we're going to go through the term first. Conscious sedation means sedating someone but maintaining a conscious state. However, there's a lot of misinterpretation. This is something we have communicated a lot around as well, especially with ADA, which is Australia Dental Association. So they tend to implement this as a technique of using drug via the IV pathway to achieve a depression of the central nervous system, so as to allow treatment to be carried out. But it does not have to be IV sedation, conscious sedation. So basically, even if you do inhalation, oral sedation is conscious sedation. Okay, it just they have misused the term. But hereby, I'm gonna adhere to what these dental association are using as the term, so we stick with it. But please understand the English really at a correct level. Okay, and very often these meaning overlap. Again, we would like to maintain a verbal contact with the patient. They are just relaxed, but they are still responsive. They're conscious, they're more relaxed. They are also known as IV sedation and twilight sedation. Okay, the safety margin is slightly less than nitrous oxide. So again, this is the one. Okay, so with the gas and with the oral sedation, usually, at least in Australia, we're fully entitled to use it. So it's not like we need special training. But with IV sedation, unless you have a graduate diploma, it will be a shared care with an anesthesiologist. And this is the setup. You must have the defibrillator, which is in addition to what we mentioned before, oximeter. You must have spare oxygen in the background. you will have the oxygen mask. This you will constantly be running through oxygen as well. However, you don't need a seal mask. Why? Because it's just oxygen. Feel free to share with us. But we will constantly be running through that and keeping an eye on the oxygen saturation as well. Whether this is anesthesiologist or yourself that have special training and put it through with the IV sedation through a vein. Now, typical example of patient that has gone through IV sedation that will say to me, Dr. Lizzie, did you rip me off because you told me it was a 3-hour surgery, but that definitely felt like 3 minutes. Okay, so again, it can be all kinds of level. There may be some audience here that have personally, say, done colonoscopy or certain things like that. That's the IV sedation option. However, they will use it a little bit deeper. So you can, IV sedation means using intravenous to administer drugs that will be sedative, but you can use it to such a deep level to achieve GA as well. Okay, so get the terms right. Pathway of administration can overlap with the definition of analgesia, anxiolysis, anesthesia. These are all, you need to understand this very well before you know what you're administering and communicating. Facilities equipment is much more. It's much less demanding, actually. The setup is not as fancy as a guest because it's less cumbersome. However, you must have much more floor space next to you. So if your surgery is quite small, you need to make sure outside the door there is a patency of the corridor or the waiting room, because you need to be prepared at all times for resuscitation. Unlike the nitrous oxide, all you need to do is reverse to 100% oxygen and we'll remove all the nitrous oxide right away. With this one, with whether they are using purposeful or Diazepram, it's very different. Okay, so Diazepram is literally the only one that has antidote, and your anesthesiologist would know well and carry it around and put it through. Okay, with most of the other medication, there is actually no antidote. They will just have to minimal to achieve the results and not overdose, and then they will have to monitor. But in unfortunate cases, whatever happened is a resuscitation. So remember, I have talked about the basic life support. This is why I need to go through this with you. Okay, so you must have appropriate drugs for the cardiopulmonary resuscitation. Obviously, the heart and the lung is the major area. That's why we check the pulse, the breathing, and all these. So these are the things that keep the whole body running as emergency. So I have listed a few like adrenaline, dextrose, like a little bit of sugar there to make sure it's ready. Flumacenil as antidote of Diazepam. Okay, and oxygen is your basic standard. There's a range of IV equipment, but that's something a little bit beyond today's topic, because I would not expect anyone tomorrow start doing IV sedation on patient. Today's goal is really to make sure you guys understand what is available, how to identify patient, know which level they are, what factors is the trigger, and introduce all these options. Do not judge. Because this patient report to be 5 out of 10, then I'm gonna just talk to this patient about say happy gas or IV sedation. Please don't do that. So the indication is if you have any patient that's reporting 3 or more, you discuss all the options and then explain the pros and cons and what level will suit them most, and then they decide which one they want. Okay, ultimately the decision is the patient. This is called informed consent. I get a little bit upset when people come to me and say, I have to have 4 wisdom teeth out, but the maxillofacial surgeon said I have to go to the hospital and go under GA. Okay, and then there are also a lot of sad cases that patient will say, I have this really bad toothache. The dentist have to do remove the nerve and do a root canal treatment. And he said that he already gave me 7 Articaine and it's not numb enough, but then there's nothing more they can do. They would just have to pull it out and it hurts so much. Okay, so these are wrong practice of pain and anxiety management. You offer full range of options and then let the patient choose which one suits them most. Okay, and it should not be it should not be treatment dictated. Just because it's non-surgical, it doesn't mean I will be fine with just LA and oral sedation. Just because it's surgery doesn't mean the patient has to have IV sedation. It can be linked up with anything. Okay, so it's about at the correct timing, identifying the correct anxious patient, offering all the options, discussing the pros and cons, which one will suit them best. They choose the one that suits them, offer that treatment. Okay. Alrighty. You will have ECG and other monitors. These will all be brought along by the anesthesiologist. Just a little video from England, that how we run things.
You've chosen to have your dental treatment under intravenous sedation. This is different to a general anaesthetic. Here are some important rules to follow before, during and after your visit to ensure your procedure can go ahead as planned. Have a light meal 1 to 2 hours before you attend. Wear loose clothing, avoiding nail varnish and false nails to help us administer your sedation and aid monitoring. If you are on routine medication, continue to take it as normal before and after your procedure, unless advised otherwise. Do not drink alcohol or take recreational drugs, including cannabis, for 48 hours before and after your procedure. Refrain from smoking to help healing. Sedation is not possible if you are pregnant, so be sure to tell us. If you're a nursing mother, you will not be able to breastfeed for 12 hours after sedation. Do not bring children or babies to your appointment. Bring a responsible, able-bodied escort over the age of 18. Your escort will need to check in with you on arrival and remain in the waiting room during your treatment. Sedation will make you feel relaxed and you may forget much of the visit. Aftercare advice will be explained to your escort and they will be given a leaflet. You will remain in the recovery area until you can walk unaided. It is preferable that you and your escort go home by car or taxi. If using public transport, take extra care. The effects of sedation can last for up to 12 hours. Rest at home for the remainder of the day accompanied by an adult. Do not care for others. Eat and drink when you feel ready, avoiding very hot or very cold foods. Do not drive or ride any vehicles, operate machinery or appliances until the following day. Do not return to work. Make important decisions, including financial transactions, sign any documents, or use social media for the next 12 hours.
Okay, so that kind of give you a brief idea what is the basic information we have to give patient. And remember about the pregnancy, that will apply to oral sedation as well. They won't be able to breastfeed for up to 12 hours afterwards or even longer personally, because remember how long Diazepram take to reach the half-life? 100 hours. Right, so they still have option. It's just they need to be aware of it. So nitrous oxide, there is this risk we just discussed with them, but ultimately it's patients' choices, not ours. Okay, all right. So the risk associated with conscious sedation here, which is actually IV sedation. So there can be much higher risk of depression of cardiovascular system and respiratory system. Obviously, the reflexes as well. So when it won't be termed as overdose. It's higher than what you intended to achieve, which is conscious sedation. Then the patient can reach loss of consciousness, which instead of sedation, it has gone to anesthesia. So this is where we don't usually want in the dental chair. If we want a GA, we want a GA in the hospital, and there is much more support equipment and the team in supporting it. Okay, be mindful of the combination of drug. It is quite important that patient go for IV sedation has to be fit and healthy. Okay, so if they're not fit and healthy, they usually fall into two categories: happy gas, nitrous oxide, or GA. Okay, with oral sedation, IV sedation, these drugs can have a lot of interaction in retarding or interacting with their current medication. So it's not advised most of the time. Possibility of excess amount and to compensate for inadequate analgesia. So we've talked about it. Individual variation as well. So this is where your anesthesiologists come in and do their own judgment. I did, so usually what we do is every fortnight Tuesday is our IV sedation day. So we have the whole day, the anesthesiologist come in. His name is Simon. He will just sedate one by one, and we're doing our surgery or clean or treatment. But he's the one that will have to check on the medical history the week before and confirm they can come in. So far there is one patient that I gave him, like usually I just give him medical if he's healthy. There's this one patient I gave him, he is fit and healthy too, but he's very obese, okay, he's very big. And then Simon has basically declined and say, no, not gonna do that, because when he lie down, his tongue is collapsing, all right? So he has a strong gagging reflex. But when he IV sedate him, what is going to happen to this tongue? It's going to collapse. And I don't know if the two of us is going to be strong enough to maintain the airway and patency. And that's why he wasn't allowed to go through IV sedation. So instead, what I gave him is a happy gas. I commence the treatment on the nitrous oxide for him, and then I just regulate it and make sure, you know, like if I'm not certain, I put back up a little bit more of the oxygen. So BMI is another thing that we have to be aware of. Wide variety, so a lot of the day surgery is done, not just dental treatment, we're just adding into it. There are different standards of equipment, staffing, again, different locations. So India may have specific guideline that you guys will want to check on. GA, so it's very less commonly used, but like I said, the two typical patients I will put through is the really sick elderly with a lot of medication, or heavily retarded that I couldn't put through. So general anesthesia is any drug or any substance, okay, anything at all that can be put into the patient and induce a controlled state of unconsciousness. So it's control, we intended to do that, but more often it's IV pathway, okay? So they will put through the vein and put purposeful in, and compared to IV sedation, what they do is they do a higher dose of propofol, and then after a certain period they're observing, then they will add up, okay? So they will monitor their ECG, their heart, and their brain activity or such, and if they see that it's starting to come back a little bit, that's where they dose up. But obviously we should all know there's a quite significant side effects, and that's why we tend to refrain patients from going through GA if we don't have to. So we're gonna move on. This is the basic setting
Right to sleep,
will
and
be
for some people
expected.
even
So this is the basic setting, and we can see the operating theater. It's very important if you're intending to set up for the GA in your practice, you will have to have a recovery area, because it will take a couple hours for them to come back before they can be accompanied by other adults. In all the sedation option I have discussed with you, the only one the patient can come and go by themselves is Penthrox and nitrous oxide, which is the inhalation sedation, because they come and go quite quickly. With all the other options, oral sedation, IV sedation, GA, they must always be accompanied by a responsible adult to drop them off and pick them up. Usually we let them stay around. Just because of COVID, we tell them they can't stay. They are only here to drop off and pick up. Now, risk associated with it, it's very similar to other IV sedation one. However, it is much more severe when things happen, okay? And then we're gonna move on. So these are, so apart from this slide, which is exactly the same with the IV sedation, so the more severe one that we can add on is post-op delirium and cognitive dysfunction. So people can develop some form of amnesia and things like that. So my mother has that. My mother had to go through a GA for a procedure, and procedure went well, okay? But then after she is recovered, she is never able to remember her birthday again unless she look at her own ID. So these kind of things are the major side effects that can happen. And it's also very common that the surgeon is doing a really good job on the GA and results is really good, where they lost the patient due to an allergy to a medication during the GA and they can't bring them back and such. So the risk is way higher here. Okay, so breathing problems as well. Obviously, we will have to, they usually have the, you know, like all the gear ready. And if they have to do a tracheotomy last minute, they are prepared to. Okay, all right, we're gonna go through advantage and disadvantage to give you a comparison so you know how to choose. Okay, the risk of unconsciousness is variable for oral sedation, really depending on the dosage. Okay, it's not uncommon that when people overdose, they can do it too. So if you remember, I was saying, I only mentioned 2 drugs, the most common one to you guys, lorazepam and diazepam. And this is the typical one when people try to commit suicide, they overdose on. Okay, so you can achieve a level of unconsciousness. With the relative analgesia, which is your gas, it's really low. Okay, and because at any time point you can just immediately recover with oxygen. Conscious sedation higher level and GA much higher. Requirement for a company, the only one that you don't require, already mentioned, is inhalation sedation. Everything else, their husband, mom, dad has to accompany them. Facilities demand as it go up to GA, it's higher. The cost of setup is also higher. Oral sedation literally is a script to the pharmacist. The cost involved, again, go up the hierarchy as well. Contraindication, so just be paying attention here now. So remember I said very medically sick people is rarely contraindicated with the gas because it's the safest. But if they are quite sick, you don't really want to give them oral sedation or IV sedation. And you would just put into GA and let the anesthesiologist manage it, and so that it can be more controlled, and it's a team approach. For the interaction with medication, again, the gas is the safest. With the others, really depends. So oral sedation, read up your interaction notes and cross-check. But I did mention the 3 major ones, antidepressant, opioids, if you want to give opioids for pain relief afterwards, and also antibiotics of particular kinds, erythromycin, clarithromycin, and for azithromycin. Level of pain relief, oral sedation 0. It does not provide pain relief. It just sedate them. They just sleep here. So you have to give local anesthetics. Whereas with the RA, then you're gonna be giving moderate level of pain relief. Remember, it's also give the fingers and papilla and the extremities some tingly sensation. With conscious sedation, it's even higher, and GA, it's complete unconscious. However, under GA patients, we always give LA still for 2 reasons. Reason number 1, we want the adrenaline, control bleeding, because they're not gonna move, they're not gonna feel any pain, you cut into it, there's heaps bleeding. So we still want the local anesthetic in their area, okay? Reason number 2, so I mentioned the adrenaline. So reason number 2 is post-op. Okay, and it's very typical that if we do a treatment, so let's say on the GA, we inject and local anesthetics, so less bleeding, we do the treatment, and right before we finish, let's say I'm finishing up, suturing up, you usually yell out to the anesthesiologist, they need to know if it's 10, 15 minutes away and they're getting the patient ready. You will, after you finish everything sutured up, you will add LA again, okay? You will add LA again before they bring them up for post-op relief, because immediately after they are up, they're really drowsy and all that. They're not quite ready to take your Panadol, Nurofen, but then they need some form of pain relief before then. So immediately before treatment and immediately before recovery from GA, we usually give LA still. Training requirements, basically for the first 2, we all can do it in Australia. For the conscious sedation and GA, you will need, so IV sedation can still be done, but you will need specific training. But then these are the area I prefer to work with anesthesiologists. Concurrent administration of oral sedative, not for so obviously oral sedation, you're already giving the oral sedative. With the IV sedation, yes, it's very standard that my anesthesiologist will ask them to take something first, and then they add on with the IV on the spot. But you can't mix that with the gas, okay? Because we're not trained enough to have, well, both, you know, diazepam or lorazepam in the body and then happy gas them. So it's not that safe. GA, obviously, it's a mix of drugs they use. So yes, they would do everything. Can administering dentists perform dental procedures? So this is more specific for Australian that we need to be aware of, that we can't do that when we do IV sedation. If we have the training to be doing IV sedation, even though we are a periodontist or dentist, then we can't be, you know, administering that and also doing it, because obviously you have monitors to watch, so it won't be safe enough for you to multitask. So case scenario, we're getting close to the end. So just discuss 4 cases so that you have an idea, like how do we judge. So first one is a young girl going to court with ex-boyfriends. These are all our cases with abusive behavior, heavy smoker. Probably we should remove the A now. So it's called necrotic ulcerative gingivitis or necrotic periodontitis, and you can smell alcohol. So here I would like to highlight, because you can smell alcohol, and it's obviously quite an acute situation. Patient present, you're not gonna say, you know, see you next week. You're gonna treat, right? And if we can't be certain the alcohol is away, then you have to be really safe. And if she's extremely anxious, which is usually the case, they are stressed, right? That's why they have this kind of necrotic condition. So nitrous oxide will be the safest one. Now with case scenario, I would have mentioned this before. Really senior, a lot of medical condition and plus dementia as well. Don't know when was the last time going to dentist and coming up with a big surgery, and the surgery say need a dental clean before the heart valve surgery. So what I would do is, I'm not going to try to oral sedate, or I'm not even going to try to IV them, because you don't know what's going to happen. It's just too much medication in there. And I'm not a special needs or specific geriatric dentist. I'm just a periodontist. So what we do is, usually we communicate with the heart surgeon and the anesthesiologist on the day that we can go in quickly, do our job, do the clean, and then come out, and then they can do the heart treatment. And obviously the patient can just go through GA once instead of multiple times. Okay, 60-year-old female wants single implant, and you have experience of her whinging of pain, and this is very standard. Okay, so usually the biggest whinger, the people that complain most, is a middle-aged female that I experience complain most. So these are the ones that you will have to consider giving them a good level of sedation. If for any patient that is considering 2 options, okay, so if they're like, I'm really scared of dentists and all this treatment, so I understand you say I'm very severe and I need treatment. So let's say I'm considering between oral sedation and gas, or I'm deciding between gas and IV sedation. I would usually, unless there's contraindication, prompt them to go with the higher one, and I will explain to them the reason why. If you are not certain and you are between these 2, go for the slightly higher one, because you don't want to go slightly under and then you never come back for treatment again, and you have created a bad experience for yourself. I've lost you. Periodontists are like your best friend for life. This is what I tell all my patients, because it's never non-surgical done. It's never non-surgical done. You will have something that goes on lifelong called SPT, supportive periodontal therapy. We have to become best friends. So the last thing I want is, okay, all right, we're choosing between these 2. Maybe I go that one, and then I turn out I lost this patient for good. Because it's not just about me losing the patient, it's the patient losing that faith in that they can have treatment in a comfortable way. So if that's the case, please consider that. Now, last case, young kid swollen bleeding gum. Mom said medically diagnosed with like fit and healthy. Kid has not been eating, and most likely it's pain related. Now with such young kids, I did mention for the happy guest to be go on will have to be 4-year-old, okay, or higher, and I'm not going to consider oral sedation. These are the ones that you probably will consider IV sedation. Alternatively, it's a co-management that I would just send it to the pediatrician. I will provide my periodontics advice from this patient, but I'm not gonna be really the one dealing with it. I usually just send it to pediatric just for better behavioral management with these kids. All right. Okay, we're finishing up with some summaries. So even if you forgot everything, please remember patient is not just exposed to topical gel and local anesthetics. It doesn't mean it's not a lecture to ask everyone to now tomorrow I have to spend so much money and buy all these toys so I can provide everything. It's about making you as the periodontist knowing what is available and that you can offer your patient all these options and guide them through what suits them most. And usually the way I say is, if I do not offer that option, I'll refer you to someone that offered that option and treat you. And like I said, it is really malpractice to tell the patient, oh, you just have to do it under GA because I will earn more money under GA. So let's take the 4 wisdom teeth out, and because they are impacted. Impaction is not an indication for GA. Impaction is an indication for, say, whatever way of removal. And then pain and anxiety management is a completely separate page to dental and periodontal procedure. Okay. So just know all your options. Transition from complete consciousness through to GA is a continuum. It's not discrete. It's not like, okay, I'm just doing conscious sedation, just IV sedation. You can at any time just slip into the other way, okay? And pathway of administration is also a separate concept. Do not just mix it up. Oh yeah, I'm just doing this level. It's not a level thing. It's the way you give them the drugs, and then what level you achieve is a continuum. It can be very shallow. It can go up to high, okay? It can be by oral sedation, you achieve unconsciousness, okay? Complete anesthesia, like when people commit suicide. So the margin of sedative and analgesic drug safety varies widely. So depending, like you need to know your medication quite well, like how you're going to use your sedative and analgesic drugs. So we are very familiar, I'm sure all of you are very familiar with paracetamol, ibuprofen, and higher level you're going to use Panadine Forte and things like that. So these are the opioids, and but it will be beneficial if you're also familiar with sedative as well. So overall, relative analgesia, which is the nitrous oxide gas, is a very, very safe option. So the minimal that I would usually, obviously you guys already have a practice, but sometimes when people want to invest and say, look, I just want to be able to offer more for my anxious patient, or if they're starting out a new practice and they come and consult me, my advice is, even if you can't do anything else, oral sedation is just as great. Be prepared to some level of nitrous oxide offer, because it's really benefiting your patient as well. Cost is another thing. Obviously, it's up to how people charge, but we charge for the guest for every 30 minutes as well. So we have a fixed price, and every 30 minutes we just put on it. Basically, we just pass on the cost of the gear and the guest, and we tell them, look, this is just gonna achieve what we need to fix in your dental or periodontal condition, but give you much better relief as well. So hopefully we can together fight off dental anxiety. So it does, no one have to really live with it, especially in the dental field. It doesn't have to be just painless. Okay, and remember, yes, people are anxious and they very often relate it to pain, but it doesn't have to be just pain. There are patients that like, I'm not scared of pain, I'm just really scared of the smell of the hospital and your gloves and the noise and the vibration. Oh my God, I know I'm not painful. You already gave me LA and I'm numb, but I'm just so scared when there's drill or something, or the ultrasonic. So this is where we step in as the practitioner to identify the correct factors and to identify it. Okay, it's not necessarily so it's history and examination, right? You take history, but what I want to say is from the psychological aspect, asking them about dental anxiety is less effective than during the paper form medical history, you know, subconsciously get them to fill that in and answer you, because when you ask them, there is tendency of them not reporting correctly due to embarrassment or whatever. So that's a better way. Now, thank you very much, and special thanks for Nymphia and Anupan for introducing me as well. But most importantly, thank you to all my lovely audience from the ISPs. I hope this was helpful. And it's a little bit behind time, but I do welcome all your questions.
Thank you, Dr. Lizzie. It was like, as I told in the beginning, she's a voracious speaker, and she has been speaking elaborately about the sedation. It is wonderfully taken care. So not much of a question which is there, but there's a question like, what is the role of alprazolam? Role of alprazolam?
Alprazolam. So it's also
idle dosage. That's all they want to know. Some.
Sorry, what?
Idle dosage. What would be the
Idle
ideal dosage? Yeah.
Alprazolam.
Yes.
What is the reason the one that asked the question would prefer to go with the alprazolam?
It was a question of one of the doctors, Dr. Jitendra. So yeah. That's what had come in the chat. So I'm not very sure what was the reason for.
Lorazepam or not Diazepram or Lorazepam?
No, it's alprazolam.
Alprazolam. So we don't use that often because it's not as safe, and also it may not last as long as for the treatment time we required. So it's harder to control. That's why we typically and routinely stay with Diazepam and Lorazepam. Nowadays, so that's why I didn't comment on that drug at all. And I was commenting on these two. It's just more commonly used if you're gonna be considering oral sedative. They are a little bit more well controlled, and also in the timing I mentioned, Lorazepam is getting more popular, more commonly used.
Okay. Fine, thank you. If there is a question, like if it's from my side, if there is nausea and vomiting during the procedure or at the start of the thing, do you continue with the procedure or send them back? Might be after some time you continue, or you want to do it in some other day?
Nausea, I will continue the procedure. So you should always have ordenastrone handy in your office, okay? If you're going to be using nitrous oxide, and you will tell the patient nausea is one of the side effects that happen beforehand. Now, not that it is related, but I still like to ask, do you usually get car sickness, motion sickness easily? And if you have been pregnant before, do you get a lot of morning sickness or things like that? So this is an indication that you keep it handy, and you inform the patient, although they are sedated, they are fully capable to give you a verbal comment and say, look, I'm feeling a little bit, my stomach feels a little bit funny. And that's immediately where you put in the ordenastrone under the tongue and making sure it is well controlled and settled. Okay, so you can, like, ordenastrone works so quick. Literally, again, in 2 minutes, it will be quite well controlled already, and you can just continue the treatment. I probably won't put it under the tongue and continue. I'll give her 2 minutes for it to dissolve and absorb through the sublingual artery. Then I will continue treatment. It works really well. With vomiting, I think that will be a bit much already, because if you have pre-operatively discuss with the patient, they should already warn you when they're feeling a little bit nausea. It should never go on to the vomiting stage, and it's extremely rare. If vomiting really does happen, obviously the staff should be well trained with the plastic bag or container coming right away. I probably will stop the procedure if that happens. But basically, in all my years of practice, and I do use nitrous oxide basically every day, I have not had a patient that vomited at all.
Okay, thank you. One more question. How can we manage an adult patient who is very apprehensive during local anesthesia administration? How can we assure the patient? Is there any
How
way?
can you assure the patient? So is this a question regarding whether they would benefit from the sedation? Because like I said, I do that a lot. So usually if patient is just very specific about needle and have no problem after the needle, I will administer the nitrous oxide just very quickly, get through the needle stage, and it's very beautifully worked out. And then you can give them back oxygen, done, remove your gas, don't charge them, don't waste more gas, and then you can do the treatment just to get them through that. Oh my God, I feel so fat now, and that's perfect. That's exactly what I want. Now you're not gonna feel it. So so if you are just to get through the needle, that's the thing. And don't be shy to look for things and talk about it. I believe in India, especially for ladies, everyone got piercing. With the ear or something. They are way more. It is really a psychological, emotional trigger rather than the sensory trigger. And that's where when you explain to them, they, instead of apprehensive, we will try to shift their mindset to be more comprehensive.
Okay, that's very informative. I have a question for myself from you. Do you usually, for dental anxiety scale of CORAS, do you use in that with the questionnaires, CORAS dental anxiety scale?
Yeah. So my questionnaire. So all new patients, they come in for the new patient consult. They have to come 15 minutes earlier. They sit down. So we use the tablet. We don't use the paper form. So there's always the question in saying, how comfortable do you feel in regards to this coming up dental specialist appointment? So we will not say, what is your dental anxiety level? Yeah, so we avoid this word. And then we will say 1 to 10. 1 is completely comfortable, and 10 is completely terrified. And after they do that, then there is concern factors. Is there particular concern that will that you would like us to address? So it's you will notice it's very common. People that report 5 out of 10, their concern is about money. They actually about finance. So they will take. So usually we have the boxes for finance, time, and actual dental procedure. And if they take dental procedure, it will come up with another 6 things. So there is vibration, noise, and things like that. So like I said, if it's about noise, we usually advise them, please, I will make sure all the question is answered, giving you the opportunity, and we'll cover everything. But once I'm about to start the treatment, please put on your headphone, like the earplugs with your own phone. And if it's vibration, what can we do? And we will just advise them. And also, patient, very standard periodontal patient complaint. Actually, it's not the pain, it's the cold sensitivity, right? It's like, oh my God, the vibration and the sensitivity. Then be considerate, use warm water. That's what we do. Like our water is 40 degrees Celsius, so that it's about identifying the factor. Then you can address the problem. But without being able to identify the factor, and they are not able to, they're not able to respond to you, and you're using your consultation time, you ask them, what scares you, or like, is it scary? And it's just very often, even if there's no one, even if no girlfriend or husband or wife there, they're not able to elaborate on it. They will just be like, oh yeah, okay. The reaction they give is giving you an underdiagnosis. So I think usually they advise you come in 15 minutes earlier, and in the form include as much as you can think of, and invite them to sit down in that corner of the waiting room and fill it up before you bring them in, and you already got your answer in your hand, so you can attend to it.
Okay, That's very nice of you. And I just want to add, would you preferably put a light background music, kind of soothing music when you're doing the procedure, so that the patient is also a little bit in that mood, or the music which they like might be in a
Yeah, so my entire surgery run with jazz music. So instrumental, no one's singing. You know, the relaxing jazz music. That is one of the one that is very good. The other one, there's actually scientific study on it. If you guys are interested, I think it will be very good as well. It's the white sound. So there are white sounds that is actually very calming. However, I don't like it as much because what happened is after certain hours, I become really relaxed and sleepy myself.
Okay.
So mute my stuff. So but I always run the jazz relaxed music in the background.
Okay, that's fine now. It is for your relaxation or the patient's relaxation?
Yeah, that's the thing. So we still want to stay focused and working, and this is why I like to stress a lot with gas. You know, I will promote people to use the new design of the mask and make sure you're still doing your work and they're not sharing as much. Yeah.
Okay, and just the last question, from my side, are you taking any different precaution during the COVID? Like the mask is whatever mask you are going to place for anesthesia, are you going to check it out? Like you are going to change whatever? Is it each mask you are using for each patient different, or you are sterilizing it and then using it?
So all our masks is disposable. So every single new patient will get a new mask. There are usually different level 1, level 2, level 3. So we usually use at least level 2, okay, for all standard procedure. And if it's surgical procedure or aerosol involved, we'll use level 3. But definitely disposable between all patients. However, the nurses are also gonna be wearing masks, and they always wear, you know, like they always change over between patient within the surgery. The guideline for them is never to wear masks at the reception. Now, a lot of practices recently started telling even the reception or the nurse to start wearing masks. If they are dedicated reception, okay, they do not ever go into the office to the surgery or anything, that's fine. They can wear masks and protect themselves and the patient. But if they are one of the staff that go everywhere, they go to surgery, they go to the patient, and they go to the reception, then I'll tell them, do not wear your mask at the reception and thinking, oh, I'm protecting myself and patient. Because when they're busy and they're working and they are not having a dedicated station, they forget whether that mask was from treating the previous patient, that was aerosol, we were cleaning and gone there and gone to the reception. So unless the staff is like, I am only a reception, then I would say, okay, you can wear a mask. Otherwise, I would just say follow routine protocol. You only wear a mask in sterilization and in surgery. As long as you come to waiting room and reception, no mask, no PPE, please.
Okay. So I think that's the thing. I would like to call upon our president, Dr. Nymphia Madam, to say a few words.
Sure.
Thank you, Dr. Chatterjee. Thank you so much, Lizzie, for a wonderful lecture. Actually, during our PG programs, when our students go for exams, a lot of questions are asked on the anesthesia. I hope you have cleared all their doubts, and many of the questions are related with what usually the examiners asked. And
sure.
Thank you for such a wonderful lecture, and it was a pleasure being with you and being with all the speakers from Australia, and we had a speaker from UK also. So with this, we end this series of international speakers on our platform, and we may be starting soon with another series. And thank you so much, lovely audience, for giving so much support to our program and being consistently there. Thank you, Dr. Subhash and Dr. Neeraj, particularly, who has been handling these things so nicely and seamlessly. Dr. Subhash is always there, the first one. He's He's the head of the department in the Cuttack SCP Dental College, Cuttack, and he's always there. Dr. Neeraj has been doing a lot of work related with putting this program flawlessly, all the sessions, and he's always there. Thank you so much. Thank you for being there. And we will meet soon with some new ideas and new programs on the ISP platform. Thank you. Thank you so much. Thank you. Miss.
Definitely. Thank you,
Thank you.
everyone. It's lovely evening. I hope you enjoy it.
Yeah, we had a
Have an
nice
afternoon, right?
interaction.
Have a good one then. I hope everyone stays safe and we have a chance we'll come to India and visit and say
Sure,
hi.
sure.
Most
You're
welcome.
most welcome. Most welcome.
Yeah, like because me and my husband can both come.
Okay.
Sure, that would be great. Dr. Neeraj, you want to say something?
Thank you very much for a wonderful and elaborate lecture. Thank you.
You're welcome. You're welcome. I hope it was fun. Thank
Yeah,
you.
it was.
Dr.
Okay.
Subhash, you want to say something about the whole series?
Sorry.
You are muted, sir. You're
Dr.
muted.
Subhash, you unmute yourself.
Unmute yourself.
Sorry, who?
No. One of our professor, Dr. Subhash
Faculty
Raj,
members.
faculty member from Madhaka. He just wanted to speak. Actually, I think.
There is no, sir, there is no Subhash in the name of Subhash, sir. So
Oh,
there is no
okay,
Subhash.
fine.
It's department.
Okay.
But-
So are you all
but-
from you are all from the same university?
No.
No. This is ISP.
We have
this
a.
is country, right?
Yeah, it's from all different universities of around India,
Right. Yeah.
and we are all working as staff in different colleges and universities.
Yeah.
Okay,
But-
thank you then. So we take leave, and it was wonderful interacting with you.
Thank you
Thank you
so
very
much.
much. Thank you.
for
Thank
the
you,
event.
madam, for the opportunity.
Yeah.
Yeah.
You're
Have a good
welcome.
one. Bye.
Bye. Bye.